Kia ora tātou, everybody. Ko Bruce Arrell aho. Bruce Arrell's my name. I'm the director of the Goodfellow Unit. It's my great pleasure tonight to introduce Professor Gerry Wilkins from Otago University, who works in the Dunedin Hospital and the Mercy Hospitals. He is quite an innovator. He was involved in the very early days of coronary angioplasty in New Zealand, and then has been involved with a whole lot of techniques and devices. I have to say cardiology sort of has more devices than probably any other discipline of medicine, but also was the first use of coronary stents in New Zealand. So obviously quite a pioneer, Gerry. That's quite a run. So welcome to the Goodfellow webinar, and we've had 760 people sign up for tonight. So it's a very popular topic, or you're a very popular speaker, or both. So.
I think it's the topic. I'm delighted to be with you, and it's an honor to share an evening with you from the Deep South. Very good. The area of heart failure is, very interesting, and things keep popping up. And I hope I can share with you this new drug that many of you all have started to use, the justification, and I guess the good news around heart failure management. Okay, so I'm going to run through heart failure with reduced ejection fraction. And it's the indication for which this drug has been approved by Pharmac as of December. But in discussing heart failure with reduced ejection fraction, that term, the R and ejection fraction, you can't help but discuss all of heart failure. So I think one of the things that I might usefully do is just talk about this idea in three different ways. Let's just talk first about heart failure in theory, the impact it makes, and the impact that treatment makes, which is enormous. Then specifically talk about empagliflozin, and then perhaps pose some practical questions in a more of a conversation. Okay, heart failure. As a medical student, we had this banged into us, but in fact, it doesn't sink in, and sometimes just worth saying again. You have two hearts, not one, and you therefore have heart signs that are related to your left heart and your right heart. If your left heart is failing, it's failing because it's either backing blood up into the lungs down there at the bottom of the picture, or it's failing to perfuse the body where the blood is going to there. Blood then returns to the right heart, and if it gets dammed up, you get signs that are much more obvious in right heart failure than for any other heart failure. Peripheral edema being the most obvious one, a raised JVP, a swollen liver, fluid around your organs, ascites. And of course, you have reduced lung perfusion, which you can't tell is going on at all. If you have both of these things together, the old term would have been congestive heart failure. I think we're better not to use that term technically, but rather say biventricular failure, meaning you know that both sides of the heart are involved. Now, lately, in an effort to try and assist with the use of evidence-based heart failure therapies, because of all the trials, we've changed the definitions, and basically we're saying now that we name heart failure after how bad the left ventricular ejection fraction, this bar here, is. So if it's severely or reduced below 40%, we call it HFrEF, or heart failure with reduced ejection fraction. We'll go to the other end. If it's normal, we call it heart failure with preserved ejection fraction. And then, of course, a simple definition ended up getting the people who couldn't stand to not say there was something in the middle, heart failure with mildly reduced ejection fraction, right? Now, let me say this straight away. Pharmac have only approved the use of this drug in heart failure with reduced ejection fraction, but disappointingly, anyone in heart failure in the trials has been shown to have an advantage with the use of an SGLT2 inhibitor. So it's peculiar to New Zealand, and maybe some other countries I'm not aware of, that if you have heart failure and you're in these categories, the drug is not available as yet. And I think you need to visually understand what I'm saying. I'm saying that you can have heart failure with the heart on the left here that's pumping really normally, all the valves, mitral, aortic working. And of course, it's easy to understand that you can have heart failure if your heart looks like this, where the left ventricle's barely moving. Or in other views, this is a 4-chamber view. This is an absolutely awful ejection fraction, somewhere around 10%. And this is an ejection fraction of more than 50%, probably 55 or 60. Okay? And it's a puzzling condition that you can have heart failure with a normal looking left ventricle. But of course, that's HFpEF, heart failure preserved ejection fraction. So I'm obviously going to concentrate today on the one with reduced ejection fraction. And it's in green here because Pharmac has given a green light to using the drug in that family of patients. But it also has value here as well. Now, effectively, I think primary care has a huge advantage the way the rules are written. Let me just go over why I think that. The way that you manage heart failure in primary care is by taking a careful history, examining the patient, such an old-fashioned idea, but very important, looking at a JVP, their edema, listening for crepitations usually, getting a BNP, and using an old-fashioned thing, even like a chest x-ray to see maybe a big heart and congested lungs, and that's reported for you often, right? And so on that basis, the typical breathlessness that may include orthopnea, cough, and gradual onset, or a history, say, of known damage to the heart from myocardial infarction or whatever, would lead you to say, I know this patient's got heart failure, right? And you would initiate treatment, and these would be things like a diuresis to get rid of the edema with furosemide. It would be to lower blood pressure if it was high with an ACE or an ARNI, and it would be to use, say, a beta blocker if the heart rate was high because of atrial fibrillation. All of these things would be strikingly obvious to do, right? But you now, in order to subdivide and indeed satisfy what Pharmac is saying is a normal practice, you need to order some sort of imaging, and generally speaking, that would be an echo, because it's the utility that we use all the time to look at heart, ejection fraction, valves, chamber sizes, and so on. And then, and this may take ages in the public sector currently, only then with the echo would you be able to subdivide them into these treatment classes: reduced ejection fraction, preserved ejection fraction. Now, is that fair? Yes, it is, because there is a different body of evidence. Drugs that work for heart failure with reduced ejection fraction have not disappointingly been shown to work for heart failure with preserved ejection fraction. So in other words, there's no evidence that a beta blocker helps preserved ejection fraction, or of an ACE for that matter. And the only drug that's really been shown to be helpful is furosemide, and in fact SGLT2 inhibitors. So I'll come back to this kind of discussion later with you. So at the moment, you would start the drugs that you saw that there was a clinical need for, and then when the echo came back and you're in this category, you're on very solid ground that you would start all of the evidence-based or guideline-based therapies from that point on. Now let's just change tack slightly and think about why you're even bothering. Heart failure at its worst is obviously life-threatening, but anyone who has heart failure of any class, 2, 3, 4, has significant limitations in what they can do. They're very limited clinically. They tend to report sort of abdominal discomfort or unwellness. They have mobility problems because of their exercise strength. Often it's associated with a real bad space in the way you feel about yourself. In fact, heart failure has been ranked as one of the worst quality of life things to have. and they often struggle to look after themselves. And it's very common and it's expensive. It's estimated in the West that 1 to 2% of the population end up hospitalized because of heart failure, and that is the leading cause of hospitalization in developed countries. It's expensive because heart failure often leads to serial admissions to hospital, and part of that is the fault of people like me, where patients aren't in long enough to actually get themselves onto the right kind of therapies. There is a high readmission rate, as high as 30% within 2 to 3 months, and a strikingly high mortality, particularly if you are one of those who ends up with repeated admissions to hospital. And it's not fairly proportioned. So here's some bars showing the age distribution of heart failure in Māori, Pacific, Asian, and European in New Zealand. Grey represents ages over 70. The lighter shades are 20 to 49 and 50 to 69. You can see in Europeans that heart failure is largely 81% of people are over 70%. Go over here to the Māori population. 16% are as young as 20 to 49. The majority, therefore, are under the age of 69, with a big number of them in the middle age group. Same with Pacific, and a sort of a somewhere in the middle thing with Asian patients. So, on average, Māori and Pacific populations have heart failure coming on 17 years earlier, with hospitalization being that point where you can declare that. This is a spectacular inequality. If you end up being hospitalized, we can think about risk in heart failure in lots of different ways. You could think about how bad your BNP is, how bad your ventricle is, whether you have ventricular arrhythmias. But here's another really simple way of thinking about risk. The more number of hospitalizations, the higher the risk. So here's one hospitalization, a risk ratio of 2.6 times, so 265% mortality against similarly aged people. 2, you go up to about 3.5 or 4. And if you're over 3, you are about 6 times more likely to die of a cardiovascular death in the year than the rest of the population. So it's strikingly clear that if you're bad enough to go into hospital multiple times, you are walking a plank towards mortality. How bad's heart failure compared to other things? This is a lovely slide. It dates from about 20 years ago from a European journal of heart failure. It's from Scotland. It's therefore a reasonable representation of the sort of, Western medicine that we have. Women, men, very similar. What are we comparing it to? We're comparing it in women to breast cancer, to myocardial infarction, and 3 other cancers. Heart failure is almost as bad as lung cancer, same in men, and worse than having a heart attack, bladder cancer, prostate cancer, bowel in men, breast, heart attack, bowel, and ovarian cancer in women. So let this sink in. Heart failure has a worse outlook than most cancers, with the exception of lung. But unlike those other things the other cancers, there are amazing therapies available which are often not used at adequate doses, or all of the whole package is not given out. And the cost of treating people with heart failure is peanuts compared to, say, the kind of complicated gazillion-dollar drugs that are used for various cancers. So as a way of spending money, I'm not trying to have a competition about cancer, but I'm just saying that you can treat a lot of people better with heart failure than we currently do. The symptoms, you all know these, but some of them are highly specific. Some of them are really general. Coming in with breathlessness has so many causes, lungs and heart, that it's hard to say that that's enough to diagnose heart failure. But there are all these others like nocturnal cough, even wheeze, which still remain quite confusing and cross over with many lung illnesses. That's where the examination, the BNP measures, the history, the skill is really important. Now, if you look at any country's guidelines, this is from the Australasian guidelines on how you should manage heart failure. This is the complicated diagram, but notice after the initial assessment, basically this line is about imaging and about a BNP, and then everything flows on from there. What are the goals? I think often in older people, general medical firms would tend to think about how quickly they can get someone who's breathless out of hospital. I think that's a fair statement. But actually, heart failure has an extremely high mortality, and the goal of treating people should be to reduce that mortality, in other words, to keep them alive if they wish to be alive. A secondary goal would be to prevent the disruption of going into hospital, and as a taxpayer, saving cost, because hospitalization costs money. And obviously, the patient's well-being, their functional capacity, their quality of life improves by treating heart failure as aggressively as possible. Now, in heart failure with reduced ejection fraction, there has been what is often called the 3 pillars, the 3 drugs that have been utterly proven to improve everything I just had on the previous page. And they are an ACE inhibitor, or an ARB, or an ARNI, the Entresto variation of, candesartan with a friend, I suppose you could call it, right? A mineralocorticoid like spironolactone, and a beta blocker from the family of beta blockers that have been shown to improve survival. And if you were to say which has the biggest benefit, it's the beta blocker, the ACE, then the mineralocorticoid. And now a 4th drug, because of evidence, has been added, a drug for the treatment of diabetes originally, an SGLT2 inhibitor, and the one that is freely available in New Zealand is Empagliflozin. So how does a diabetes drug turn out to be probably more useful as a heart failure medication? Well, SGLT2 inhibitors effectively allow more glucose to be excreted when a patient pees, and in doing so pulls out salt and water, natriuresis, right? So the left-hand side here, diuresis of glucose increases. That's how they lower blood sugar. You pee the glucose out. But in doing so, water moves with the glucose, and it's salt and water. So in other words, it has a diuretic effect mediated through different channels than furosemide or thiazide diuretics. And it turns out this is still early on. The cardiac effects may also be partly related to changes that are going on in the same sodium glucose pumps that are in every other cell as well. But I think the way to think about it currently, the truly proven thing, is basically a different form of natriuresis. Now, we can talk about it later, but how come it works in people who aren't diabetic? Well, they excrete glucose as well at a higher level, and more salt and water will come out. Will it be less of an effect? Yes. People who have very high blood sugar will tend to have a much bigger excretion of glucose because there's more to excrete, and therefore a bigger natriuresis. But the effect is present in heart failure at a level where it is absolutely proven to reduce the key endpoints. Now, we're slow to move. European and US guidelines moved on heart failure with reduced ejection fraction in 2021, and then trials that allowed all forms of heart failure in HFpEF mildly reduced ejection fraction and reduced ejection fraction showed that the effect was present in heart failure preserved ejection fraction, and guidelines in Europe, for instance, by 2023 included all forms of heart failure as recommended. So the 4 pillars would apply to reduced ejection fraction, because that's where those 4 drugs have been proven. But in heart failure with preserved ejection fraction, there is value. How do we sort of quantify this in ways where, you know, a person can understand or we can understand? Well, here's a position statement from my colleague Rob Doughty and others in the heart failure working group of the Cardiac Society, the New Zealand part of it, who did estimates from data that would suggest that a 55-year-old person with heart failure and a reduced ejection fraction, the combined estimate would say that if you had all 4 classes titrated up as in guideline medical therapy says to maximum doses, 8.3 additional years free of either death or first hospitalization is your gift, compared to just, say, starting a bit of enalapril and a small amount of metoprolol and leaving it at that. So this is across all people. That sort of gain is very important. Now, Bruce, I'm going to switch now to empagliflozin. Is there anything that's pressing that we should discuss at this point?
If you're waiting for an echo, it's up to 2 years. Now, I know there's a clause on empagliflozin, and I think on Entresto, that in situations where you can't get that, you're able to apply the special authority. Is that correct?
I love this question, because that's exactly what I was driving at when I said you guys are in a better position than we are in hospitals. Because in absolute truth, right, you're not hoodwinking Pharmac at all. If you cannot get an echo, you can apply the use of empagliflozin as it's meant to be in every other country. So what I encourage you to do, and Bruce is saying the same thing, is it says literally in the request that if you can't get an echo and you believe they're in heart failure, you can tick the box and the patient gets not a year, but a lifetime approval. And when you eventually get the echo, and it could be next week or it could be 2 years away, you don't have to cancel it, right? They've already got the approval, and that's actually appropriate clinical care. So one of the things that I'll end up saying to you, and I'll say it now, is that you should start this drug as soon as the diagnosis is proven, and that's the BNP's up and you see a big JVP and swollen ankles. And you shouldn't start all of the bits of treatment one after another. You should just get on and use it. That's what the recommendations say.
Another interesting question. I don't know whether there may be an answer to this, but with you're trying to get a special authority for Trulicity, you can't be on empagliflozin.
Yep.
But can you request a GLP-1? They're not available now, so it's not a thing. If the patient's on empagliflozin for heart failure, can you then get a GLP-1 for diabetes?
I think they were saying that if you're treating diabetes, you had to have one or the other. But if the indication is heart failure, it is independent of any other drug that the person has. And I think when it comes back in, they'll have to honor that. I think. But obviously my mind and Pharmac are not always the same.
No, I think that's probably the case. I guess it's not going to be tested till Trulicity comes back on the market. So.
Right. But of course, there are in most people's minds indication for using GLP inhibitors, it's Trulicity, in heart failure now. There's a whole lot of trials of survival in heart failure for that class of drugs as well. And it may be within a year or two that we'll have 5 pillars, right? And the treatment there would be probably initially for those with diabetes, and then it may spread out. Now, I've got, that's my next slide. Here we are. I noticed when I quickly looked through these slides that the last time I got the slides out was just before, in early December, before approval. It's not proposed anymore, it's real. This is what's written down. The patient has to have heart failure. That's a clinical syndrome, so you tick the box. If they've got really minor heart failure, class 1. Now, class 1 heart failure means that you can go jogging, but maybe you can't jog as fast as you used to. 2 is you're breathless when you exercise. 3 is it's interfering with daily activities, like, sweeping, climbing the stairs in the house. And 4 is breathless all the time. So these are the only people that are going to come and approach you, actually. So 2 to 3 or 4, you tick that box. And here's the bit that the questioner was asking about: an EF less than 40%, or you just want to get on and use it because there's heart failure. Please do that, because by the time I see them with an echo, I'm not meant to do that, right? So it's a benefit if primary care professionals start using this drug early on in terms of the patient's well-being. You're also meant to have had them on concomitant optimal treatment. And if you don't know exactly what you're using, it's back to that original comment that I made. Treating atrial fibrillation, treating hypertension, diuresing them is optimal care when you don't have an echo, right? And clinical judgment is required there, not some kind of magic formula. So what are the indications? In New Zealand, Empagliflozin, Jardiance, is indicated in adult patients with heart failure, class 2 to 4, independent of left ventricular ejection fraction, with or without type 2 diabetes, but Pharmax only covering off the reduced ones, right? And it reduces the risk of cardiovascular death and hospitalization, and actually it slows renal decline as well in this group and other subgroups as well. Now, here's a trial that we should at least have a cursory look at to understand. This is the Emperor reduced ejection fraction trial, phase 3, about 4,000 patients randomized to, note the dose, just 10 milligrams, not dose titration, just start 10 and don't increase it up because you're not trying to lower the blood sugar, you're treating heart failure, versus placebo. And in this trial, everyone was absolutely on the best of other treatments, all the other 3 drugs. They were absolutely optimized. And then they were followed for 16 months, and they had a number of, first primary endpoints like death and hospitalization or worsening of heart failure, and some other things like reduction in the number of hospitalizations and kidney function. And just let's look quickly at these things to understand the effect. In the left-hand side is the cumulative estimate for hospitalization and death, the combined endpoint that they're talking about. And this is the treatment, and this is the placebo. So the treatment lowered the risks of dying or ending up in hospital. And the risk reduction, the relative risk reduction, is 1/4 of the patients were better off. The absolute reduction is a 5.2% reduction in that. And the number that you need to treat is 19 to reduce 1 event. So that's quite a low number in the needed to treat category. Now, with the deaths, the driving thing, it was mostly about hospitalization because it's 4,000 patients in 16 months. The effect, however, was looked at, and here is the 2 groups diverging, and they continue to diverge over the days. This is 40 to 50 days. So the probability of events continues to drop. So it's not a one-off effect, it's a sustained effect. This is a key one on its own, hospitalization. The relative risk reduction is a 30% reduction. That's important because if patients end up in hospital, they're worse off, and lots of hospitalization is a marker of high mortality. So I guess if you had a bigger trial, you would see a death alone as an endpoint if you followed patients for a longer period. That's what that would say. Now, this drug affects renal function by diuresis. So if you push people on furosemide too hard, they end up dried out and they end up with acute renal failure. And that's an absolute bugbear of life in hospitals and in primary care. In this trial, renal function was watched very closely, and you can see the adjusted deterioration in eGFR is worse in the placebo group than in the empagliflozin group, such that there's a 4 times slowing effect in the decline of renal function if you're on empagliflozin. Now, where does this effect come from? This group would have been on more furosemide, and because the effect of adding empagliflozin is that you get a better diuresis and you need less furosemide. So that's an effect of the drug combination. But secondly, empagliflozin actually has a renal protective effect all on its own that renal guys are very keen to use and is indicated in its own right. And I'm obviously not going to talk about that tonight. Here's the slight hooker that you've got to be aware of. When you start empagliflozin, there is an initial fall in the eGFR, which comes back to normal, and then very gradually over the weeks here, you're a winner. And the decline in renal function is always slowed compared to a group who don't have empagliflozin but are in heart failure. Now, in talking about this with one of my colleagues, Rob Walker, who's a pretty colourful, good speaker, a nephrologist, his answer to questions about, well, when should we worry about this is not to check the renal function really early, because you'll just worry about it and you may overreact and stop a drug that actually is proven to be really useful. So by all means, understand what their renal function is and check it again, but perhaps leave it for 4 to 6 weeks before you have another look, unless there are clinical issues that indicate it. In all other endpoints in this trial, and these are the ones about how people feel about themselves and what they can do, the empagliflozin added to standard guidelines treatment. See, they're all to the right and they favor empagliflozin and how you feel about yourself and your quality of life, etc. What about side effects? So was volume depletion worse since it enhances heart failure management? No, the placebo and the Jardiance are about the same. Hypotension, no worse, right? But what is more likely to happen, and it's a small number, is a slight increase in urinary tract infections because there is an increased sugar in the urine, which can enhance the chances of infections. Now, is this important? Well, in this trial, there was no difference between the placebo and just urinary tract infections in general at about 4 to 5%. Real genital urinary tract infections were slightly worse with the treatment, but it's around the 0.6 to 1.7%, and it shouldn't put you off using the drug. Renal infections are worse in people who are diabetic probably than the non-diabetic population. So if you were to think about bad things happening to kidneys, so needing dialysis, actual renal failure, being in hospital, leading to transplantation, like profound issues, in general, being on the Jardiance or the empagliflozin made you a winner compared to the heart failure group without the empagliflozin. And that risk reduction is about a 1.5 absolute risk reduction, because it's a reasonably rare event to have big things happening. That's why. So key thing, one drug, one dose, 10 milligrams once a day. You do not up titrate for worse heart failure, and you don't break it in half for lesser heart failure. There's no titration. It doesn't matter when you have it. Anytime that people have a diuretic effect, they probably should take the pill in the morning, but actually there wouldn't much wrong with taking it any other point of the day. So I think at that point I'll have another break, Bruce, if that's helpful to any other questions that might come out of that sort of stuff, the regulatory side of it.
Quite a good question. Are you ever too late to start empagliflozin, like, I guess, respiratory wise or renal wise?
So we're not meant to use it when the eGFR is below 30. All the renal guys are saying, hell, that's probably one of the few things that might help their renal failure. But the evidence in this heart failure area, you got excluded if you had an extremely bad set of kidneys in that study. So what I've just shown you, there's not enough evidence to immediately extrapolate heart failure into really bad kidneys. But there's work in progress that would suggest that it's perfectly safe to use. You have to have kidneys. So if you have no way of getting a diuresis, of course, it doesn't help. I think that, go ahead, Bruce, but I'll just say that there is evidence maybe that there's more of an effect than just on a diuresis. It may have cardiac effects, and we may see that emerge as a kind of an indication later.
I certainly know colleagues get a bit anxious when they see the eGFR drop. I know with the renal artery stenosis, it's okay to have a 50% change. Is there any number at which you might stop the empagliflozin if the eGFR sort of?
I think you'd use that kind of rule of thumb as well. If you saw a massive decline, you'd probably kick yourself for testing it too soon, but also you'd have to respond to it, wouldn't you? So you'd withdraw it, you'd wait 2 or 3 weeks, you'd see if the thing improved, and then you'd probably throw out more frusemide, because mostly eGFR falls if you've over-diuresed someone. And we'll get to this, but generally speaking, when they're really wet, the drug is easy to introduce. If you've got them in a state where they're probably, the JVP is normal, they've got rid of most of the edema, then the way you would introduce the drug is probably swap it out for frusemide if you've just got frusemide, or at least if you've got a lot of frusemide on board, halve the frusemide and introduce the empagliflozin. So don't go hard with empagliflozin on top of full dose frusemide when the patient is well through the treatment of heart failure, right? If they're incredibly edematous, go hard with everything. But later, for milder forms of heart failure, halve the frusemide. Say if it's 80, go to 40. If it's 40, go to alternate days, or, that's sort of a management strategy. And then add the empagliflozin as the core drug. Now, what we haven't said, the elephant in the room is probably not said enough. No one's ever going to do a trial of frusemide and survival in people who are dying of acute pulmonary edema, because of course it saves lives. But in chronic heart failure, frusemide has never been shown to keep you alive longer, while these other 4 drugs have. So it's okay. In fact, it's a triumph to kick the frusemide out eventually, because it plays around with your kidneys and lowers your potassium, right? So it's not necessarily a good drug to use in the long run. So I guess always try to get rid of it if you can, but be cautious about pulling it out too abruptly.
I heard many years ago that the problem with furosemide is it stimulates the autonomic nervous system, and that's the reason to get rid of it. Is that does that make sense, or is that?
Very much, Bruce. I think that's right. So remember that heart failure is a amplification of survival things that we've got in our kidneys. So we've got the RAS system, where if you are bleeding to death or you're in the desert and you're trying to stay alive, those things that hold on to salt and water and push your blood pressure up are incredibly good. But they're the very things that are the enemy of your heart in heart failure. as is the highly increased sympathetic drive. So higher heart rate, higher circulating adrenaline. Frusemide, if you're using too much of it, switches those two mechanisms on, dials them back up. So it adds all of the problem back in if you're drying someone out too much with frusemide. Whilst empagliflozin doesn't seem to have those same issues.
This is equal, and you want to get people onto disease-modifying agents ASAP. Is there one you would consider starting before others? Is there any batting order there?
So all of the guidelines have gradually shifted to saying the same thing. Start everything at small doses together. Now, you may well end up, if in those patients who present to you with, massive edema and extreme breathlessness, they're the ones who often are indicated for sending to the hospital to be initiated in treatment. But there, clearly, the emphasis initially is on diuresis, the people who are maybe 20 kilos of fluid over numbers or whatever, edema to the waist, that kind of thing. That sometimes is best done in hospital. But all the guidelines basically say that no matter what the situation is, we should be adding a bit of everything. Now, if you don't have the echo, early on, then you are using good clinical judgment. So it'd be just slow heart rate with a beta blocker if you're in AF, and you'd slow that by introducing, whatever, choose a drug, metoprolol at a decentish but small dose, 47. And the next time you see them in 3 or 4 days, you might increase it to 95. So you'd be cautious with that drug. You would start with, if the blood pressure is very high, it's easy. You start with a big dose of, say, candesartan, or immediately apply for and get hold of Entresto on the basis, well, you're not meant to do that, but you're meant to have tried one of the other drugs, but I think there's quite a bit of just going straight for it in bad heart failure. You would start perhaps half of a spironolactone, and then 12.5, and you would add empagliflozin 1 tablet straight away. So cautiously add a small amount of everything appropriate to that patient's blood pressure, hemodynamics, heart rate.
The real problem I always think with heart failure, and this would be familiar to you, is, I guess as a cardiologist, to up-titrate those drugs. But the problem for we generalists is there's no signal to increase the dose. We've got to consciously keep up-titrating. Any suggestions for keeping us on that up-titrating? Because the patient isn't obviously better or obviously worse with up-titrating. We're just going on the best evidence.
Yeah.
It's not like blood pressure where, if it's not down to 130, 90, you keep going.
Yeah.
Any suggestions there?
So over the years, as I've taught, senior medical students and fellows and registrars, I've come to the conclusion that the best way to free people's minds up about this is to think about heart failure in the same way you think about chemotherapy. So in other words, you've got metastatic whatever. Someone says you better have the chemotherapy. And when they say that, you're going to feel unwell when you start the drug, and it's going to go on for a long time because there's a dose effect. You wouldn't send someone down for 1 dose of a chemotherapeutic agent that required a cycle of 30 doses or something to have an effect. And heart failure is that kind of thing. We are pushing as hard as we can to get people on to moderate to large doses of each of those agents. Now, 2 of them you only need to go to quite, empagliflozin, 1 tablet, spironolactone, 1 tablet, usually 25 milligrams. And it's the other 2 that have the effect of lowering the blood pressure rather dramatically sometimes, or slowing the heart rate, where we're usually not game to go straight out and put people on big doses. So in a way, the best way is to think about chemotherapy. The evidence is that you need, so if you think about, let me just go through the drugs, you probably need at least 95 rather than 190 of metoprolol. You probably need at least 5 to 10 of bisoprolol. Carvedilol, you try to get them to 25 BD. So in other words, that's where the survival benefit was seen. So you're trying to get them to that dose. And in a way, you're trying to ignore the blood pressure. So sometimes it's best not to take it if the patient says they don't feel lightheaded. I know that sounds like I'll be struck off, won't I, for saying that? But in fact, the blood pressure sitting at 100's fine. The heart loves it as long as the brain's coping with it. And you're telling people to stand up slowly, put up with a little bit of minor lightheadedness. Now, if they're falling and breaking things, that's different. But, I think we're a wee bit quick to stop and a bit, you're saying this, we're not so good at pushing, right? And it's just about dose and time to get recovery.
I saw something recently, and I think I wrote a gem on it. I do a 2-weekly gem for the Goodfellow members, that rapid up titration of the neurohumoral blockers is a good idea in general. There's an extra gain if you get up quickly.
Yes.
So we need to be a bit courageous, I guess.
Yes. The worst heart failure, the really edematous, the marked sinus tachycardia, just be a wee bit cautious about slamming a big dose of a beta blocker in quickly, because the immediate effect can be in that small subset to take away the last bit of contractility, for the first 3 or 4 days, and they deteriorate. So you concentrate on diuresis first, shrinking the heart a bit, and so on. But be quick if you have those kind of markers, massively high BNPs in the many thousands, very marked tachycardia, low saturations, to think about hospitalizing that patient for them to be seen and looked at much more quickly.
We notice that the cardiologists don't seem to be worried about low blood pressures.
No.
We start having panic attacks when it gets down to 90 and things. Questionnaire NZF suggests titrating up Entresto 2 to 4 weeks after initiation, but can we titrate after a couple of days?
Yes, in hospitals we do that all the time, and particularly if the lucky patient is the one patient with a high blood pressure and heart failure, because you got more to reduce, and therefore the left ventricle is going to love you.
With the 10 milligram dose, do we need to consider euglycemic diabetic ketoacidosis, or is the dose too low?
No. So in that study and in all studies where we're using empagliflozin in people who are euglycemic, in other words, non-diabetics, the incidence of hypoglycemia or any other measure of, oh my God, the blood sugar is too low, is a clinical non-event in the trials. So collapse, dizziness, low blood sugars meaning something doesn't happen.
If a patient is a type 1 diabetic on insulin with an HbA1c of 77, has heart failure with reduced ejection fraction, can one prescribe Jardiance 10 milligrams daily, even though it is contraindicated because of the risk of ketoacidosis? I don't think that's correct, is it? But anyway.
No, it's not contraindicated, but so the rule of thumb, and remember that I look after patients with diabetes, but I'm not a diabetologist, is that if you are adding metformin, you don't need to dose adjust, or if you're adding it to metformin in an existing patient, you don't dose adjust. But if you are adding it to sulfonylureas, which are not used that much, but to insulin, you would reduce the dose. All right. So there is a dose adjustment down in insulin, and that would apply to type 1 diabetics as well. Now, the risk of ketoacidosis and so on is increased, and that's in some of the slides. So if I push on a little bit and ask, so in other words, you initiate all 4 pillars at low dose, you up titrate every 2 to 4 weeks. We've come to that conclusion in discussion, and you'd review 1 to 2 weeks for each medication and check things like blood pressure and heart rate and renal function and serum potassium. You may at some point switch from an ACE to an ARNI because you're allowed to if you don't think they're making progress. And you should be having a washout for that. If it's an ACE to an ARNI, that's all in the guidelines for that use. And of course, SGLT2 inhibitors don't require dose titration. You just give it to them. So let's just ask a few more of these kind of silly questions, because I think silly questions are good, aren't they? What if this guy had type 2 diabetes? Does the presence of type 2 diabetes change what you do for heart failure with reduced ejection fraction? The answer is yes and no. If you want to lower the blood sugar more, you'd give them a higher dose of empagliflozin. But as a management of heart failure, you just need 10 milligrams. And this is where I already saw this. So what the question that was being asked, is it different, therefore, that do people with diabetes get a bigger deal when they have heart failure? The answer is no. If you look at the Emperor study, that study we just looked at, and you looked at those with or without diabetes, the survival benefit, 22 and 28% relative risk reduction, is the same, right? So the effect upon heart failure is an independent thing. It's not only if you have diabetes, and it's not bigger in diabetes. That's quite revealing, isn't it? The problem with diabetes is, with the drugs, is that you can end up with more sugar in your urine, and you end up with more genital infections. But the effect is a small one, and the effect about severe hypoglycemic episodes without diabetes was a non-event in the trials at all. It was more likely in diabetes because they're on other drugs that reduce blood sugar, right? Now, what's the biggest problem can be that it will create a situation of ketoacidosis. But so will continuing to take blood sugar lowering drugs such as insulin when you have diarrhea, vomiting, and you're not eating. And in a way, you should think about this in just the same way. If you're going to be fasted for an operation, or you're sick in some way with an acute illness, then you should stop taking the empagliflozin until you're eating and drinking normally again. And if you're just doing it because of an elective operation, probably a couple of days would be enough beforehand. But currently, most anaesthetists are asking for 3 or 4 days without the drug on board before significant operations, orthopedic procedures, gut things, and so on. So in other words, if you add dehydration, no food, and you continue to take empagliflozin, surprise, surprise, you'll end up with ketoacidosis. And the rate of that is actually pretty low. So it's one of those things where there's a lot of writing, but it actually is pretty much common sense in any drug that is a diuretic, including furosemide, that you wouldn't want people hammering away with their furosemide when they're vomiting and have diarrhea, or for some reason they are sick and not able to drink. So hypoglycemia, no different. This is more about a renal impairment. Does that answer that group of questions, do you think, Bruce?
We haven't got any questions on that, except what is your guidance for starting Jardiance for those with chronic hyponatremia?
I think, there are some people who just have these funny electrolytes, and you blame every drug and you stop that drug and it never seems to get right sometimes, probably a 50% hit rate. I think in general that I've not seen a trend to say, oh, I can't use it in that minor renal abnormality. So I think it's suck it and see. I don't associate the use of the drug in my own personal experience with hyper or hypokalemia or hyper or hyponatremia particularly. So I think it would be one of those things where you give the drug and see what happens. And if it got impactful clinically, obviously it wouldn't be useful. It may be that if you are able to reduce loop diuretics by using empagliflozin, that electrolyte abnormalities will improve, because loop diuretics are famously guilty for this. So what if the guy or gal, we got Ken here as a picture, had moderate renal impairment? Because this has already come up, so we'll just cover this off. So let's say he's got an eGFR that's down 58, but not too bad. Well, Jardiance or empagliflozin reduce the relative risk of the composite of cardiovascular death and hospitalization for heart failure, regardless of your renal status. Whether your kidneys were good or bad, it had the same effect. So here is that compared with chronic renal failure disease, without, or the other way around. They're the same numbers. But very low eGFRs were excluded from the trial because not enough data really to know until, I guess, when you get this answer, there is a trial underway to try and answer that. So this is about renal failure. You're not going to adjust for chronic kidney disease, and indeed chronic kidney disease is an indication if there's proteinuria for the use of empagliflozin, and I'm not talking about that tonight. You might, for type 2 diabetes, and just adjust it up, but that was for the diabetes, not for the heart effect. That's the 10 milligrams, because people without diabetes get the benefit the same when you give them just 10 milligrams across the board. So that's answered well and truly in the trials at this stage. Now, do you have to adjust it? The diuretic dose, and we've already said this as well. So in Emperor, 86% of people were on diuretics. So these are a genuine heart failure. And it was found that basically there was a contraction of blood volume, the signs of it in the kidneys, and reduced blood pressure and so on, when thiazides and loops were not reduced and people got more hypotension. So you should consider reducing the diuretic dose when you introduce empagliflozin or an SGLT2 inhibitor of any sort in your well-managed patients with heart failure. And in the early phase, you may want to reduce the diuretic a bit as you put it on board. Are there any safety considerations that you should be aware of when you're prescribing? Well, here they all are. We've talked about them. Volume depletion, dehydration because of the enhanced diuresis, but you often back out of the thiazides and the loop diuretics. Ketoacidosis, we've just spoken about. Infection rates, I'll cover that a bit better in another slide, but really bad necrotizing fasciitis of the perineum is reported in patients with diabetes because of sugar-rich urine anyway, but those rates rise slightly with the use of empagliflozin. But this is a rare thing. Here's about the numbers. The reported incidence with Jardiance, 10 milligrams is 4%, with 25, 3.9, now they'll be diabetics, compared to placebo, 1%. So that's all sorts of any kind of infection of any sort. But truly severe infections like fasciitis, much rarer. I don't have numbers on that, but known as Fournier's gangrene is rare and obviously life-threatening. It occurs without SGLT2 inhibitors. Because of the slight increase in infections, you would have a slight increase in this over thousands of people on drugs. Practical tips, basically, it's about managing cleanliness, wiping, treating early, and managing those sort of infections. I've had patients where I've managed them for their for heart failure, and they've had recurring urinary tract infections and have had to stop it. And if that's the case, you have to stop. Sometimes you can reintroduce, but mostly they're recurrent. But it's quite rare in my clinical practice to date. What if a patient's going to undergo surgery or is sick? Well, we sort of covered this off. Patients should be made aware when you're briefing them on the drug that if they are lowering their blood sugar and peeing out more water, if they stop eating or drinking because they're sick or someone asks them to stop hydration or food because of an operation, they don't need the drug, and the drug could be dangerous. And so it's common sense sort of stuff, really. And that would include remembering with elective surgery of all sorts to have the patient identify that to anaesthetists in the days beforehand. So stopping early and not having the drug on board for elective procedures, and just stopping the drug if you're dehydrated or unwell in any way. And guidelines will change. I think at the moment they're longer than they need be, but probably people take a while to get used to a new family of drugs. What monitoring is required for SGLT2 inhibitors? Well, actually, probably not much. If anything, renal function improves, so you don't have to, once you've established the drug and they're well on it, you probably don't have to constantly check kidney function. People are recommending perhaps yearly, but a patient with bad heart failure, you're probably going to see them every 3 months or so, and you could look at their renal function, their BNP, probably at least 2 to 4 times a year in the management strategy, because watching trends in BNPs, initially funders were trying to stop us doing that, but it's one of the most useful things to know which way patients are going. Not the absolute number, but the direction of travel, and relate it to the way the patient feels. And obviously, volume depletion, it's about what we've been speaking about. Don't be worried about that initial dip, because in the long run, the patient's kidneys are protected by the presence of SGLT2 inhibitors, and that emerges over the years that follows. It's not the early dip. Even the early dippers get a benefit over time. All right, so the decline in eGFR is slower for the patients on SGLT2 inhibitors in heart failure. Why do we see the early dip? Well, because the effect is in the proximal tubules, you end up with less sodium and water coming through. So you have an effect where the loop diuretics and so on, the glomerular pressures are dropped, and you end up at a decline because of that. There's not so much filtration going on because the proximal tubules have already lost some of their volume. And I suppose any new agent that's got a proven benefit, you've got to sit down and think, am I using this drug enough? And remember, basically, this is a fairly friendly drug to use, which helps kidneys, and it doesn't need up titration. So it's a relatively easy drug to introduce, to be honest. And so I find myself thinking of it quite early in pretty much every patient with heart failure. I'm going to make one little plug here as I finish. To be honest, you think of it most when you have edema because it's in the diuretic category, but theoretically, we should be adding it to everyone who's got established heart failure. I'm not rushing into doing that. If people are well and they have low BNPs and their heart's sort of recovered, I'm not sure that we should be putting every single person on it just because there is evidence that you need it at the beginning. I am quite impressed with its usefulness in heart failure with preserved ejection fraction. And my plea to you is that if you're allowed to use the drug early before you get the echo, use it, because I think you're benefiting patients justifiably. That's what Pharmac says you're allowed to do. For patients where we know that they have normal ejection fractions, patients can self-fund it. And the cheapest way to self-fund it, and I think the pharmacies have got used to this, is that you prescribe a 25 milligram tablet and tell them to break it in half, because 12.5 is close enough to 10, and that's half the number of pills, and therefore you drop the price by half. So online pharmacies sell 25 milligram tablets for somewhere around $80 for a month, and it would cost about $40 for a month if you self-fund it. And I've asked lots of patients, and somewhat to my surprise, patients in heart failure think it's worthwhile because they're pretty upset about the way they feel. And probably that's about it.
Yep, got some good questions here. There's a little bit of a discussion here about type 1 diabetes. Apparently NZSSD says not recommended for type 1 diabetes due to blah, 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 without specialist approval. Although something else I found says it does seem to improve glucose control. So what's your view on that? Would you just leave it up to the diabetologists?
If the reason to use it was blood sugar lowering, yes. But if the reason to use it is heart failure in the type 1, there's absolutely strong evidence that you should use it.
Yep.
So split that in your head. So in a way, I suppose we should call the drug a heart failure drug, not a diabetes drug. I think it'll end up being used in more patients with heart failure around the world than it is for blood sugar lowering in the end.
Any advice for Ramadan? Do you have to do anything about that?
As I understand Ramadan, you're allowed to eat and drink, but not over the long period of the day. So I would try to hydrate when you're allowed to hydrate fairly maximally, and I would probably omit the drug if you felt really dry and a bit lightheaded by the end of the day, or try to use the drug around the same time that you're also hydrating. So I would be cautious about Ramadan if the effect upon that person was to feel pretty lightheaded and unwell, which some of my patients who observe Ramadan tell me they do.
Question about frailty. I had an extra look at the SPRINT trial for hypertension. Interestingly, lowering blood pressure only worked in people who were frail. Actually, people who weren't frail, it didn't have a benefit. Working the front. I think we steer too clear of the frail people. I don't know what you think. But anyway, is there a level of frailty beyond which you wouldn't give this to a patient?
No, because it doesn't have any effect in a metabolic sense. It's not lowering the blood pressure. It's not lowering the blood pressure much. It's not making them hypoglycemic. And we talked about this, I think, probably off air earlier, Bruce. My patients come back and thank me that they're on it for a reason that I didn't expect, and that is that it smoothed out the explosive diuretic effect of a loop diuretic. And a lot of frail people find that really difficult to get to the toilet with urge and incontinence. And a lot of people are really grateful that empagliflozin is acting just as well as the furosemide that has been replaced. In fact, it's got a survival benefit, but they don't have that immediate urgency when they take furosemide, and it's much nicer for patients. It's kinder. So in fact, if anything, I'd say it the other way around. I think it's an ideal drug for the frail.
That's been terrific, Gerry. I think people have commented there saying how wonderful that's been as a tutorial. You really have covered a lot of grounds there, and given us some very good ideas on how to manage with this new medication. So on behalf of the Goodfellow Unit, just like to thank you very much for this evening. I think it's been terrific.
I'm pleased to join you, Bruce. It's been fun. So it's nice to have a chat. All right. Thank you for all the participants as well. And thanks for hosting us, Bruce. It's very good. Enjoyed it.